Hi guys, welcome back to another video from the Aspiring Medics. My name is Yusuf, I'm an Oxford medical student and I'm also joined by...
I'm Megan, I'm a first year Oxford medic and I'm at St Anne's College.
Great, so of course today we're going to be going through an Oxbridge mock. These are infamously to find on YouTube and it's really important to get the right practice as well. And guys, remember it's all about how you're able to think as opposed to what you know as well. And we're going to be going through some data interpretation in this station as well and we'll really be able to go from there. If you guys are new, don't forget to like, comment and subscribe. It really helps and it means we can create more videos just like these. All right, so we're going to get started. So I just want you to have a read of this, and for readers at home, feel free just to pause it, the video, and you'll be able to take a read through it. Okay, so Megan, I'd like you to explain to me this data, please.
So we've got two graphs here, A and B, and on the x-axis of both, it's time and days after immunisation, and then on the y-axis, it's the EAE clinical score, and then they explain in the table above what that means. So a score of 3 seems to be sort of the greatest severity because it's paralysis of both hind limbs and forelimbs, and then 0 is kind of like the lowest level of severity with like normal motor function. And then on graph A, there's 3 lines. So one is no treatment, one showing the I think IG is probably standing for some sort of antibody because immunoglobulin. So that's like sort of an antibody treatment as a control, and then a treatment called anti-lingo-1, which I'm not too sure what that is.
So if I say an antibody against a specific protein that they think could be contributing at least to multiple sclerosis in mice.
Yeah. Okay. And then with B, we see a comparison between the antibody control and then this other anti-lingo-1 antibody. And then sort of difference between the graphs, it seems to be that there's like a slightly, oh no, the time scale is roughly the same. I think the graph A kind of goes on a little bit longer, 36 days after, and then I think graph B goes on to about 33 days, but it's sort of roughly the same. I think graph B is comparing those two treatments directly.
Yeah, so if you're looking then at graphs, so if we have a look, you've clearly illustrated what the table means. So as we say, EA clinical score of 3 is the most severe form, where we've got paralysis of both hind limbs and forelimbs. So basically, the lower the EAE score, the better the outcomes are, okay? Now, could you just walk me through graph A, please?
So in graph A, we can see that the no treatment has the kind of, the lowest, or the highest EAE clinical score, because it kind of has the steepest curve from time after immunization. And then the control treatment, the antibody IgG treatment, is just has a slightly lower EAE clinical score in time in days after immunization, but it's not like dramatically lower. And then the injection of the anti-lingo treatment shows a much lower EAE clinical score from time, like with time after it's injected.
Great. And my question is now about IgG. What's IgG? Have you heard of that before?
Yeah, it's a type of antibody. I think it stands for immunoglobulin. I'm not too sure how you say it, but I think it's...
Yeah, immunoglobulin, exactly. It's just a subtype, immunoglobulin G. Why are they comparing anti-lingo-1 to IgG control? What is a control here and why is it needed?
A control is sort of expected to not have an effect. So it's kind of like to get basically a baseline level of maybe in this case the EAE clinical score, what it is when you inject an antibody that won't have an effect, because they're probably wanting to compare. Obviously no treatment could be seen as a control, but they're not injecting an actual antibody, whereas the IgG is an antibody and so is the anti-lingo-1, as you told me. So it's sort of a comparison between an antibody they think could have an effect and an antibody they don't think will have an effect, so you can see the baseline difference from just comparing the two antibodies.
Good, but being devil's advocate, why couldn't you just use no treatment as a control?
I think it's going back to this idea that injecting an antibody itself will cause a response.
Very good.
Yeah, so you need to basically be able to compare it to another antibody.
Yes.
See what the response is with an antibody in the first place to see if the antibody you're specifically using is going to have an effect.
Okay, great. So you can clearly see that in graph A, the antilingo 1 has a massive effect there. What do those arrows show? You've got two arrows there.
So the arrows are showing, are they, so time days after immunization, maybe that's an injection of the,
Hmm.
and of the antibody, so day 3, although it does say time days after. Is it a booster injection potentially? I'm not sure.
Yeah.
Yeah,
So it's a booster injection.
yeah.
So if it is a booster injection, how many total injections are the mice receiving in the control or antilingo 1 group?
So in the control group, they're receiving 2 because there's not a booster. Or there is another arrow actually, I think above the, so in graph A, for the anti-lingo, they only receive 2 because they get the one. Oh no, they receive 3. Sorry.
Yeah, yeah.
Yeah.
So they each receive three. That would also be shown in the methodology, but good. They each have three. So, okay. And if we now look at graph B, what does graph B show you?
Graph B is comparing just the IgG control and
Hmm.
the anti-lingo one. And they receive a lot more boosters in this one. So 1, 2, 3, 4, 4 boosters and then the original. So 5 injections in total,
Hmm.
I think, is for that graph. And
Good.
there's
All
a
right.
different number of participants as well. I think that's what the N equals is potentially.
Yes.
So there's less in each of the groups in
Hmm.
graph B.
Good. Anything else we can see here?
Um, the clinical scores, I think that's roughly the same. They show the
So
time
if we,
intervals are
if,
different.
mhm.
They
Yes.
have
So,
like it goes up in different numbers of days. So like it skips to day 2 and then day 4. Whereas in the first graph, the initial time period it basically they show the data every day, and then it skips to every 2 days from day 6, I think. But it's done slightly differently. Basically, the scale is slightly different on
mhm.
graph B.
Yeah, very good. So you've got different scales there, and it isn't the same, is it? Sometimes it's compressed, sometimes it's more stretched out. So very good. That's really good to know. And out of these two graphs, which do you think is most relevant when it comes down to and applicable to clinical trials and to real life when it comes down to patients?
I would probably say the one where they use a larger sample set. So I'd probably say graph A because
Mm.
one they're comparing all 3 treatments, and also they've just using a larger number of mice. I mean, obviously the difference is not that great. They're still using quite small numbers of mice in
Hmm.
all for all of the treatments they're giving.
Mm.
Um, but I'd probably go with graph A. Um,
Okay. And even if you, so let's say actually, you know what, the numbers for both graph A and B were exactly the same, firstly. And now if we're actually having a look, what else could you also help to decide? You spoke about no treatment, and that's a fair enough argument. But as you say, actually, all we need is control and anti-lingo 1. What else can help you decide? What else can you see that's different about these two graphs?
um, I mean, they both have like range bars or error bars, but they're quite sort
Mm.
of similar in terms of like the differences like the deviations they show. I
Good.
mean,
So you don't have overlapping data bars
yeah.
there. Good.
I mean, B obviously is doing a lot. Like they show a lot more booster injections. Um,
Yes, that's true.
so that's potentially a reason why. Like I think it's probably more realistic to have them as it is in A, because they're giving them really frequently. Like they do they do an injection I think at day 20 roughly, or day 18, and then they do another injection like 4 days later. And if you're using this as a treatment, then you
Hmm.
should be having injections really regularly. I mean, it is a possibility obviously, but
Yeah.
like with A, there's like more time between each injection, so that's probably more feasible as a treatment if you were to apply this to humans.
And if you're actually having a look at where the injections start, what times do they start? And what was also happening at that point when you're looking at the first one that was given?
So there's a
Or
slight
let's go with the first booster that was given.
so it's given roughly day 3 after the first immunization, the booster in A.
Hmm.
Um, whereas the booster is given much later after the first immunisation. So we see an increase actually in the EAE clinical score before the first booster is given in B, whereas we don't see that in A.
And is that relevant, do you think?
I mean, potentially. I mean, they're suggesting that basically because there's a booster's not given as quickly, the EAE score starts to increase before they give the booster. So maybe yes, but then we're assuming that the booster does have an effect on keeping the EAE's clinical score low. So it kind of makes sense that it's like that, because they give the booster earlier in A, which prevents that rise, but they don't give it as early in B, which then it starts to rise, and then they give it, and you sort of see a slight kind of dip in the anti-lingo treatment. So obviously the EAE score is going down after you give the booster.
Sure. So if we take a step back from this more generally, because this is an important point, and you made an important point there. So there's a difference in terms of whether they actually have the treatment, if they have symptoms or not. Yeah, that is the crux of what we're talking about here. Now, if we take a step back, do mice usually get, these signs of multiple sclerosis in a month?
I'd say probably it's probably difficult to record data over a month. I mean, they're not tracking them. Yeah, they're not tracking either of them for very long. And so to be able to judge, I mean, paralysis of both hind limbs and forelimbs, so the greatest kind of extreme of EAE clinical score. I mean, I don't know if that could happen over the course of a month.
But I mean, does that happen in usual mice, in a month, that they all get MS and they get paralyzed?
No, it's not typical that happens.
Okay, so what do you think's happened there then?
So they've had to somehow manipulate the myelin around the nerves of the mice, so they can sort of stimulate an environment that's like MS in humans. So they've maybe they've given a drug that kind of demyelinates neurons, or maybe blocked the function of production of myelin by one of the cells, myelin or something along those lines.
Good. So they've got this mouse model, and as you say, they could do that either pharmacologically, i.e. with a drug, or they can do that genetically in terms of genetic editing. They could either do that within, like, in terms of embryonic, or actually in terms of further development as an adult mouse, for example, that can also be done. So of course, what we're looking at here is a mouse model, right? And so the first thing to ask you as well is the fact that you are giving this treatment before symptoms versus when they start to have symptoms important when it comes down to real life clinical practice?
Yes, so I guess it's important in terms of seeing when's the optimum time to give treatment. Can we give treatment earlier than to prevent the EE clinical score increasing?
Yes.
Versus obviously it's slightly delayed in B, and then we see an increase in EAE before they give the booster after, because they give it later in B. So yeah, it's quite relevant in terms of you want to give the treatment before symptoms start to escalate. So yeah.
Okay, so you're saying why do you want to give the treatment before things start to escalate? How are you basing that on the graph?
We can see in B that when they give a booster, I mean, they give the treatment initially in both of them, but giving a booster earlier then prevents that EAE score increasing as rapidly, because we don't see that increase. They give the booster slightly earlier date in A for the anti-lingo treatment, for example, and then we don't see the EAE scores increase rapidly. Whereas in
So you're talking about here, around this point?
Yeah.
Good. And what about their endpoints? I
mean, they both end on if we're referring to the anti-lingo treatment, they both roughly end at a similar score of about 1. I mean, roughly similar, about 1.
Good. So if you were to say it in one word, A, what is that more of in terms of if it were to be used in clinical practice?
Graph A?
Yes. Like in terms of anti-lingo in that circumstance, given that it's before symptoms, what is that more likely? What is that being?
It's preventing myelin from getting, so it's basically resulting in less demyelination of neurons of of the axons. So
What do you call it if you give something prophylactically before something has?
it's a preventative measure. So
What's another word that we all have as kids, and that there's been a lot of talk about this in terms of COVID jabs. What's that known as?
vaccination.
A vaccine. So
Yeah,
A is more of a vaccine, yeah?
I see. Yeah.
Whereas B is more of a what?
B is more of kind of a regular treatment. It's not being used to prevent as such, maybe. It's being more used as a management method.
Very good. So graph A is really showing anti-lingo 1 more as like a vaccination, whereas B is showing it more as a management. Yeah.
Mm-hmm.
And as I say, which do you think would be more relevant when it comes down to multiple sclerosis?
I mean, I think probably management of a condition. They both end on the same EAE clinical score. So you'd probably need to keep injecting the anti-lingo relatively regularly because we don't have data.
Mm-hmm.
We do kind of have data for this, but in B they keep injecting the anti-lingo treatment and it kind of keeps the EAE clinical score relatively kind of plateauing or almost decreasing slightly. But in A, you can actually see it's very slight, but they give fewer boosters. They give another booster slightly later, but it does start to increase slightly. And we don't know, obviously, we don't have data beyond, I think it's 36 days, but I was kind
Very
of
good. Yeah.
It starts to increase slightly from that point.
Very good. So you'd want to have a further timeline to actually, okay, what does that then have an effect on, and how are they doing? Yep, that's very good. What else would you consider? So if you're now the health secretary for the NHS, would you fund style A or style B? And what sort of factors are you going to be considering?
I mean, obviously, style B is potentially more expensive because you're giving boosters more regularly, and they're going to have. I mean, they might be able to administer them at home, or someone come to the house, or they might have to come into hospital, and obviously that's got costs. And also just in terms of actually having to have more of the treatment because you're giving it more regularly. So it's a lot more costly potentially to do B, but long term you won't have to see these patients as often, maybe if their EAE score remains lower because they can better manage their condition independently. So then that increases or frees up capacity. So ultimately, I'd say B is a cost-effective option because although you spend more to carry out this treatment, long term, you'll probably spend less because these people won't require as much attention from the health service.
Good. And what would you want to compare this management option to?
I mean, if there's another alternative treatment to MS, good. I don't know if there's like a drug or something else, but yeah.
So what are you comparing it? So you're comparing it to the gold standard. What metrics are you looking at there?
So I'd want to look at, I mean, EE's clinical score seems like a good way of determining like the level of management of the condition. So you do a comparison with EE clinical score of from the drug. So say you've got a drug to help kind of manage the symptoms of MS. You could compare the EE clinical score with treatment of the drug with injection. So
just to pause you there, you're thinking of using the EAE clinical score for clinical trials for humans?
You probably potentially yes, although you couldn't use it in the exact same way because obviously this is specifically for mice, but you could do an adapted version for humans.
Yeah, so you'd want, of course, that do an adapted version depending on the different symptoms, but because of course we don't have a limp tail that we're ever going to get. So I think it's important to obviously put that into account there, and also consider the fact that, well, what else would you also want to consider when you're going from a mouse model to more clinical trials?
I think
so you've mentioned.
There's also considerations in terms of like how the patient can take the medication or like their ability to be able to actually use it, because obviously a drug is relatively straightforward to take in comparison to injecting a antibody into yourself or etc. So accessibility of the treatment is really important. We also want to think about maybe other effects. We don't know how, obviously we're trying this on mice, but we don't know how maybe there's other adverse effects of this antibody injection on humans, which we don't see in mice, or which we weren't testing because we were only really looking at paralysis. So those are two factors.
What adverse effects are you thinking about there?
I mean, maybe even things like allergic reactions, sometimes injections.
Yeah.
Obviously, injecting an antibody, it could have knock-on effects on other immune cells or other cells in the body, which maybe you don't see in mice for a certain reason.
And what could that lead to?
I mean, that could, if they're other antibodies, then maybe it could suppress your immune system. I'm not too sure if that works, or it could,
Yes, it could almost cause like an autoimmune condition. Good. And you also considered administration, and you've also spoken about comparing it to a gold standard where you're looking at its efficacy, i.e., how well is it able to either improve lifespan or in terms of reducing the symptoms. And of course, you said about using some sort of modified clinical symptom calculator or scorer there as well. And you also mentioned about adverse effects, and we mentioned about anaphylaxis or autoimmune as well. So I guess lastly, thinking about actual clinical practice, why else is B favoured over A?
I would also say, I mean, what else are they doing in B? They're giving.
So is the crux of it is still because of the fact that with B, the management is when they start to have symptoms. Why is that important? Why is that more realistic than A?
Well, you're likely not to have identified someone who's got MS before they start having symptoms. So
Precisely.
people might not know they have MS, so you wouldn't have given it before they started having symptoms.
Absolutely. And it's precisely that reason that usually MS is only diagnosed, at least at the moment, when people present either to A&E or GP with these symptoms of fatigue, vision problems. However, if you were thinking about A, in terms of in the future, what could you want to consider then if you did want to go for more of a vaccination for MS?
I mean, you could identify certain risk groups. I mean,
Mhm.
I don't know if MS has sort of a genetic component, if it runs in families in a way.
And it does. There is a genetic component.
Okay, well,
Yes.
then you maybe want to identify people with a family history, and you can do that through the
Mhm.
GP, and then
Mhm.
those people can be identified as being in a risk group, and you could potentially sort of vaccinate them before they do develop symptoms, even if we don't know if they've got MS. I mean, we need to study this
Good.
in people who've not got MS just to check it's not got other effects if you don't actually have MS.
Sure. And just to pause you there, so you mentioned about family history. Now that's quite, easy to do, but can you think of anything more precise that could be done?
So we've identified people with a family history, and then within people who maybe have a family history, it's certain other risk groups. So people of a certain age. Oh, actually, you could do genetic testing. I don't
There
know.
we go. Yeah, absolutely.
Yeah.
Genetic testing would be really useful to find out, right? In this circumstance. Good. So thinking about stratifying those at highest risk of either inheriting that condition, if we can find out the interaction of different genes, and if we can correctly sequence their whole genome. Very good. And you quite rightly mentioned that you'd also want to do in healthy volunteers, i.e., as part of the usual clinical trials, anyways, to see the effect of it. And therefore, going back to you as the head of NHS England and thinking about cost effectiveness, what also, therefore, would you want to consider when you're thinking about a vaccination in that circumstance, even if you're going to stratify it based on genetics?
So we need to, if we have identified the people who are basically most at risk of MS or are going to develop MS, having done the testing, we need to basically think about when we give those individuals the vaccine, or so I mean, potentially we could give the vaccine if we can. I don't know if we can even test from babies, that might be too young, but you could even do it from like a really young age, done with like sort of integrated into the rest of the vaccine program, so it's not a separate thing, but it's done kind of aligned with other vaccines that are given when to like reduce costs in that way, so it's not a whole separate program.
Okay, so you're okay, very interesting. But what else would you want to think about in terms of costs? You gave a really creative example of, doing it with other vaccines or, creating a multi-vaccine to be done in that way. And of course, it comes again to that efficacy point. And, you mentioned about this graph also increasing, so you'd want to see it over a longer time span as well. But what critically also would you want to know with a vaccine?
I mean, we need to identify, I mean, some people don't want to have a vaccine, so I think that's another thing. So if there's any
Yes.
within that at-risk group who aren't going to, or are maybe not sure about having the vaccine,
Sure.
that's important. But in terms of costs, I I mean, obviously there's preparation involved in a vaccine, and there's sort of resources required to create vaccines and then produce them, and stuff required to give them. So there's costs in that sense. Maybe there's a way of minimizing production costs, or like something.
Yeah, so what is the calculation? How do you find out if it's worth doing so? If it's worth having an MS vaccine? What are you thinking about? So you're thinking about, yeah, sure, the base costs and the factors that could influence a vaccine in terms of actually, you know, administering it and also manufacturing it. But what else critically are you going to be thinking about in this vaccine, in this scenario?
We want to look at the actual, like, is it worth it in terms of the effects? So when we vaccinate these people with the MS vaccine, obviously that's got a cost. So is this actually long term? You kind of want to do a study where you follow these people long term to look at the costs of treating people with MS, but without the vaccine versus with the vaccine, and then work out if it's cost effective in that sense. I mean, that's an option. But then
sure, so with that, as we've said, so with the treatment, you know, with B, option B, we're doing it as if they've got the symptoms, and with A, you're saying you'd also do it with the MS patients and see how they do with vaccination. What else would you also want to consider in your cost calculation?
Potentially the cost of the medication, or like we talked about the gold standard treatment. I mean, we could compare the cost of
yes.
to these.
What else would you want to consider within the vaccine group that you'd want to consider with the genetic testing? Because of course, genetic testing, why are we doing genetic testing again?
We're trying to identify the risk groups. So that obviously genetic testing has a cost as well to it.
Yes, that's very true. And it is very expensive. That is true. What else? Are you just getting MS patients in the high risk groups?
Not necessarily. We're also getting people who don't have MS. So,
very good. Why is that important?
Oh, so we could be vaccinating people who don't actually have the condition. And obviously could be seen as a wasted cost.
Exactly. So then you're looking at, okay, well, how good is our genetic associations at being able to predict who's got MS? And that leads me quite nicely onto this when we're thinking now more generally about predictions. All right. So bit slightly changed, but we're now thinking about it in terms of radiology, in terms of AI, and actually you can start to predict or actually diagnose someone specifically with having MS. Okay. So you can diagnose someone with having MS using an MRI scan, and you can tell that. Okay. Now, with the new breakthroughs in AI, you can actually use either radiology alone, AI alone, or actually do radiologist combined with an AI. And you've got here specificity and sensitivity. What do these words mean? Have you heard of them before?
So I have heard of them before. I mean, I understand sort of specificity to be sort of kind of like how accurate something is at detecting a certain, say in this case, a certain condition. Where sensitivity is more generally picking something up. So if we're talking about, say, a radiology scan, if it's got high sensitivity, then it'll be able to pick up a condition. But specificity is its ability to identify like a specific condition or a specific disease that you want to identify on a scan.
So sensitivity is that, did you say?
Specificity is about specific, like picking up a specific disease, and sensitivity is more broadly about just picking up or identifying a disease.
Okay, close. So if I tell you that sensitivity, well, firstly, let's take it to COVID lateral flow tests. If I say, for example, that they are not sensitive, but they are highly specific, what could that mean to you?
So if they're highly specific, they'll only identify the COVID. So if somebody has COVID,
very good.
They identify COVID. They won't pick up, other viruses. But they're
good.
not
So
they might not always pick up if you have COVID. So
fantastic.
Yeah.
So if we just break that down, exactly as you say. So then having 2 lines testing positive on a lateral flow test means you absolutely, if it had 100% specificity, you absolutely have COVID. That's what it means, because it's very specific for it. Yeah. So if it is positive, it means absolutely with certainty you've got it. But with low sensitivity, you said that it can miss cases of COVID. And that's absolutely right. So it's important to consider that, because depending on that, you can either get false positives or false negatives. If you've got a low sensitivity, you're going to get lots of false negatives in this. And this is something to also consider when you're going through this. All right. Any questions so far?
No question.
Great. Okay. So what does this table then show you?
So we can see, so we've got the two columns, specificity and sensitivity. With the, it's comparing obviously the three different radiologist, AI, and then the combination. We can see the highest sensitivity is with just AI alone. And then, is with the combination. And then it's quite close though with the AI alone. And then radiologists on their own have the lowest sort of sensitivity in terms of detecting a condition on a scan. And then the combination has the highest specificity as well as sensitivity, but the AI alone has the lowest specificity. So I would sort of understand that to mean that the AI alone, it's quite good at detecting an abnormality on the scan, but it won't be able to detect the specific condition or disease that causes that abnormality. I'm not sure if that's correct.
Not necessarily. It does mean, so sensitivity, we said, what does sensitivity mean? So with AI alone, 99.1. Let's round up to 100. So what does that mean if we said it was 100?
So it'll always detect the disease on the scan or a disease.
Yeah, so it'll always detect. If you do have MS, it will always detect it. Yeah? With 100% accuracy, it won't miss a case, basically, if you're at 100%. But if specificity was 50% as it is here, what does that mean?
That 50% of the time there'd be a false positive. Is that correct? Or they basically detect it, but it wouldn't be MS. So we're talking about MS.
Exactly. And it could be normal, it could be a different disease, but it could just be nothing at all.
Yeah.
Good. What are, and this is not a trick question, so if we then think about this false positive, what are the consequences of having a high false positive rate?
I mean, if you're detecting a lot of people to have a condition, then you might start them on treatment for the condition. Obviously, it's like the cost of actually treating or managing a condition. So you kind of, those costs are a little bit wasted in that sense because they're not going to benefit from them potentially. And also there's an emotional aspect to it. The patient thinks they've got a condition which they don't actually have. It could potentially be quite mentally damaging or difficult. And also then you prevent, if it's a different disease, you're actually slowing down the process of them getting diagnosed with another disease, the one they actually have, and then obviously
very good. Very good. Excellent. And what are the consequences of having a high false negative rate?
If you had a high false negative rate, then you miss out on detecting people with a condition. That slows the process of them starting treatment. Then their condition could progress before you obviously put in place measures. So it might be more difficult to cure if that's possible, or more difficult to manage long term. And also then at some point they may find out and then they may be sort of frustrated at why it wasn't detected earlier. So there's that sort of aspect of it. Yeah.
Fantastic. So if you were to design a method, and it's always a way up, and of course you'd want to optimize both, but would you rather have a system in which the investigation has 50% specificity and 100% sensitivity, or would you rather it have 100% specificity and 50% sensitivity? Which of those two would you rather have?
I think I would rather have 100% specificity, because although you will miss sort of certain cases, you always know that the person's getting the correct, or is being referred, everyone who you detect is being referred to the correct course of action. You're not going to get those sort of people thinking that they have a disease which they sort of don't have. So although you would miss cases by having a lower sensitivity, at least then everyone you detect is getting the right course of treatment. I think that's what I'd probably...
That's very interesting. Okay. What do you think has a more impactful consequence? Do you think it is, missing disease? Or do you think it's causing undue worry
I mean,
Which of those two?
I would say obviously missing disease has got quite a large effect, but then you could potentially start someone on another treatment, which then could harm them if they've got another condition which you're treating them incorrectly for. So I think there is the emotional aspect, obviously. Like, I don't want to cause emotional harm, that's why I'd go for a high specificity. But I think there are like physical dangers of having a low specificity, because certain say you start treating someone with treatments for MS and they have a different disease, your treatment you're giving for MS could also potentially progress their other condition further, or you're missing the condition anyway, really, and you're not treating it correctly. So it's still having the same effect as if you didn't pick it up at all. So that's why I'd go for a high specificity.
That's interesting. Personally, for me, I'd actually prefer to have 100% sensitivity, because I'd rather ensure that I'm not missing out completely on a condition. And as long as I'm aware of the fact that it's got 50% sensitivity, it's 50% specificity, I could then do a further investigation just to be able to make sure that it is exactly what I think it is. But arguably, one could say that it's much better to not miss out on a condition rather than it present 10 years later, particularly if we're thinking potentially not about MS, but if we think about something like cancer, where catching it early really makes a big difference. Arguably, having a high sensitivity matters more than specificity, because as long as you can do further tests, it's much better, therefore, just to rule in or rule out something, arguably. But that's really interesting. Megan, I think we're out of time, but thanks so much.
No problem.
And thanks so much, guys, for watching as well at home. We hope you found it useful. As I said, please do subscribe and do comment as well. We go through each and every single one of your comments, and we'll see you in the next one. Take care. Bye.